communities for which it's a minor consideration, it hasn't caused a great deal of devastation, has not stressed their healthcare system. And other communities where they don't have enough space or people to bury the dead, outbreaks like in Italy, Ecuador, Mexico City, New York City. So today we found out, for instance, that Russia sees the largest single case jump in cases. They've ever had 8,000 new coronavirus cases in 24 hours. And right next to that is a report from South Africa where they're doing well. It's going away. They passed their peak and they're reopening the economy. The next news item says New Jersey reporting more daily deaths than any other state. On April 30th, there were 460 coronavirus-related deaths. And you remember for a while, New York City was reporting 500 to 600 deaths per day, which is just hard to fathom. And then they point out the final bullet point, and I don't want to belabor this, is Hubei province in China, where this all started. The last case has been reported now, has been for a couple of days, and they're relaxing their restrictions, which were quite dire, but were successful. So this strain of respiratory virus is more like the 1918, 1919 Spanish influenza, which was highly contagious and highly virulent. At that time, we had no vaccine, no antivirals, but they did find that the distancing, closing of churches, closing of schools, and non-pharmaceutical interventions of that type were successful, and they have been demonstrated to be successful in the current outbreak of COVID. So with that little background, I'll see if anybody else wants to add to that.
Bonnie or Paul, anything you want to add?
Well, one of the things that has struck me about it is, of course, it's very different from anything we've investigated recently in public health process, but it is a process, and things with this particular one being so new are just going to keep changing. Anything that was reported, a few months ago may or may not still hold, because we have a lot of new things to observe, a lot of new things to investigate.
Tracy asked if you guys think the numbers are underreported. Anyone want to answer that?
I totally think they're underreported, not because anybody's trying to not report them, but simply because we haven't had the testing, and what's become very clear that we have a lot of asymptomatic cases out there because they are obviously exposing people. And I believe that now we're doing more testing, numbers are going to consistently rise for quite a while.
I agree. The other thing to keep in mind is that makes this infection different from other infections like SARS or even like Ebola, is that you can shed virus for 2 days, for 48 hours prior to any symptoms. So it's very difficult. But if you're dealing with a smallpox case or an Ebola case, as soon as the person gets sick, you put them in isolation, and you can do a pretty good job of containing the infectious nature of the process. But that's not the case here. And in fact, the highest levels of virus are found in respiratory secretions for 2 days before you have any symptoms.
Paul, you want to add anything to that question? So, our understanding of the illness?
Not at this point, I don't.
Okay, so one of the basic questions I had is this a virus we will all eventually get, or is it one we can avoid? And the setup for that is because way back in February, I read an article in The Atlantic saying this was just going to become one of the seasonal viruses, with the very grim outcome of lots of illness and lots of death. But one reason it seems that this is important is it gives us two different understanding of the public health measures and the lockdowns. Are they a temporary strategy to prepare the medical system for some inevitability, or are the measures themselves meant to help us completely avoid getting the virus? I've read both explanations. I'm sure other people have too. So kind of help us understand, is it a virus that we can avoid and get past, or that's going to just kind of, we're going to have to learn to live with? And then how do the public health measures help us to deal with either of those realities?
Well, I'll take the first part of it. Public health measures are very well researched, and typically what happens in any kind of an outbreak is you notice that there's cases increasing, but these are all ones that in the past we've had some experience with. However, the process is the same. We still need to be doing, identification, case finding, whatever mitigation needs to be done, isolation or so on, and then you just repeat and keep going on until the information that you need is there. In this one, of course, we haven't reached entirely that point where we know all the information, and we may not for a long time, but we will be able to, I believe, and of course there's, this is all process. I'm a huge process person. We need to be aware that probably a vaccine is going to be developed. We're not just waiting, trying to hold off till there will be enough resources entirely, but that's a really good idea for right now because we're trying to control it. But as time goes on, there will probably be good treatments. There will probably be excellent ways of identifying it and vaccines. Then everything's going to change. Whether or not it's seasonal, I don't think that's actually been, yes, there's evidence that it does kind of slow down as things heat up, but there's also been a lot of outbreaks in the tropics and other even dry areas. So during this process, we're going to figure out a lot, and eventually we're going to have some kind of a handle on it, and we will be able to manage it in a way that we can function better.
I agree. It's there are a number of ways that an epidemic or a pandemic can stop. One is if majority of people become immune to have infection and survive and have antibodies to protect them from future exposure. And when an infection is aggressive and is with such high morbidity and mortality as the current one, COVID, we would hate to have to kind of wait out until 3/4 of the population had antibodies. But what the public health measures do, they buy you time to work on the vaccine, buy you time to work on antivirals, and I think we're seeing some of the benefits of the non-invasive measures by public health. Another way you can end an outbreak is to develop a vaccine, and the government's put a lot of faith in that, and hopefully they'll come up with something by early next year. Mike Osterholm of University of Minnesota think tank has just made a statement yesterday that he says it wouldn't surprise him at all if this were still circulating in 2 years. As Bonnie said, we don't understand the epidemiology of this infection. We know it can be underground and pop up. In Omaha, for instance, where we had very few cases early on. But as long as it's in the reservoir and as long as you have a susceptible population, it's possible it could pop up and cause an outbreak as it did in Grand Island.
So
Hey, I might just make a comment about the influenza has a characteristic that may be involved in this situation as well, which is that if you're a high-risk person and you know you've been exposed to someone with influenza, there are known treatments that can then change the course of an illness should you become symptomatic. But that requires timely recognition of the situation and starting of a treatment protocol within a fairly short period of time. And frankly, we don't have the primary care resiliency within our society to think about that now that we have this situation. So whether or not that same scenario would apply to COVID is, it seems as if there is a lag time between when you become symptomatic and when you get really, 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 really sick. I'm not too sure I understand that, but I'd be interested in Phil's thoughts about that.
Yeah, the incubation period is 2 to 21 days with an average of about 5. And some people get early symptoms and some get late symptoms and some have almost no symptoms. Clearly the patients who are older and have underlying conditions are more likely to get sick or to die from the infection. But there have been a number of, they're uncovering all the time these unusual syndromes like strokes in very young children that are blamed on the COVID infection. So I think we not only have a lot to learn epidemiologically about this virus, but we have a lot to learn clinically. These pandemics go different ways. The SARS just sort of disappeared. We never developed a particularly good therapy or vaccine. Others fall in and circulate with the annual influenza or respiratory virus circulation that occurs in the winter primarily. And others may, and most of the epidemiologists seem to think that this will continue to lay submerged at a low level of a small number of cases and then hit a vulnerable population like a nursing home and cause a large outbreak that could spread to the surrounding community. So there are a number of scenarios, but I think this problem will be with this as we think about some of the psychological and theological implications of sheltering in place. We need to hunker down and prepare for what could be a long-term process.
So I think lots of us have very specific questions about all sorts of things about the disease and the virus and, and its treatment. Let me ask a kind of broad question, and then in the midst of that, maybe you can address some of the specific ones. But all of us have been watching over the last few weeks a very public scientific and medical debate as your profession, figures this thing out and how to understand it and treat it. But all of that has very profound moral and public policy ramifications. Of course, usually these scientific debates don't occur quite so publicly and in the open and with it impacting everyone in the world's daily lives. So help us to better understand the process of trying to understand the virus and why we keep reading things that one week that disagrees with something we read the next week, and then help us understand kind of what would be the best sources for us in order to have the best information for us to understand the virus and what we need to be doing.
Well, I think I'll start in and let the other panelists dive in. But there are plenty of sources for knowledge about the medical and economic and psychosocial aspects of this disease. Sources like the Washington Post and the New York Times will let you have access to generally access to COVID articles on a timely basis. JAMA and some of the medical journals will allow access for people without prescription because of the unusual circumstances. And there are multiple other media outlets. There's almost too much information, which can lead to media fatigue, or as Nicole, I heard her mention this morning, Zoom fatigue. You have just too much to digest, and this was demonstrated after 9/11. As you know, that if you sit there and watch disaster news long enough, you'll become a psychological casualty.
I really agree with that, Phil. I was for a period there, I was totally engrossed, and then I had to step away for a while. Total total exhaustion from all the information and sorting it out. Mostly, you can hear different things from the same source in a very short period of time because things really do change. However, in any case, it's just very important to be sure you've got a reliable source. I appreciate that Phil mentioned JAMA. I always go to the CDC, and I've also heard from the CDC some things that that I question periodically, but I also know their process, and I know they're working through it, and they're not going to put information out there that they don't believe in. So yeah, they may be a dab behind some of the things, but they're not going to speculate. And any number of things. I even question a lot of news sources, even the ones I usually rely on, because they do have a point of view and not necessarily the background to differentiate. So you just have to be extremely discerning.
Right. Well, the other thing I find the media, the radio and the television coverage in many instances good and very timely, but also tends to be anecdotal. They like to focus on the one extreme case of the patient who received drug X and 2 days later is out playing tennis, and now everybody thinks we found the cure, and they want to have access to this miracle drug.
Yeah, the general mantra of medical care that sort of evolved after World War II is that most maladies could be solved by a magical drug, and some can be, which then aggravates it. And if you recall that a lot of the fundraising themes still are kind of hinged on finding the magic cure for this or the magic cure for that, and that's just a holdover from that time period when that's taken over the entire healthcare industry. It's interesting that there's a YouTube. What's his name, John? Or that you sent me those two sources where the person had looked into treatment for syphilis way back in the 1910, 1920, using fever to treat the induced fever to treat complications of syphilis. And there were whole basic institutions in the Northeast in which they would actually infect people with malaria and cause their high fevers and make them better, and then they treat the malaria with quinine, which would then get rid of the malaria. And wow, I mean, these are kinds of things that we don't even think about these days. So anyway, it's interesting how our evolution of therapeutic thought evolves over long stretches of time.
The final thought, I think it's the confusion of all of us watching the media is enhanced by the fact that there's a real schism between individuals who are focused on the human morbidity, mortality, and others who are focused on the economic disaster that's impending as a result of COVID. So if you speak to people on different sides of that issue, you get different interpretations, and I think there's going to have to be some trade-offs.
And that's something I just wanted to mention. That's something that public health process is always taking into account. We do not just deal with one side of it. It's the whole package.
Before, in the planned questions, we were going to next go to some of the understanding the public health a little bit more, but we've got a bunch of questions about the still about kind of understanding the disease. So let me throw out a couple of these, and then maybe some others we can get to later. Sally wants to know about testing numbers. You know, how do we, where do we find information on the number of tests being done, where they're being done, on whom, the proportion of positive cases for the number of tests? I mean, how do we understand the testing numbers? Where do we find the best ones? Anyone want to answer that?
I think that's a public health question, and it was on TV last night about the sites where they're doing the Nebraska testing and Iowa's testing. A number of states have taken the strategy that they can basically test their entire population or a large percent of it. They'll have an idea about the epidemiology of this organism. I'm not quite so sure, because if you have a negative test, then you have a negative test and you could get infected a week later. So I don't. The other thing is tests have been delayed. They've been used extensively in Europe to help map the epidemiology, but they've been slow to be procured and to be used in the United States. So Bonnie, what about your public health view of this?
Exactly. There is a concern with just mass testing, because for that very same reason. The way that public health recommends and the way that seems to be the most effective is case identification and follow-up. If you know somebody, if you find out someone's been, and they're doing a great job at Douglas County, you can feel incredibly confident in your particular health department. They identify all the cases possible, and somebody contacts. And I've watched and participated in those investigations, and they are thorough. And they will ask questions that nobody even realized was going to come up with an answer of who someone was exposed to. And that way, we're really targeting testing on who we at least know has been. I mean, what is the point, in my opinion? And Vicki and Lamar Jones they're up at Spirit Lake, or they're up actually at Okoboji for their quarantine, and they've had one case a long time ago, and they knew where that one came from. So the point of testing that entire county evades me. But if they had that, when they had that case, if they did the kind of follow-up they do in Douglas County, they probably got them quarantined and probably contained it. So the idea of just mass testing is, and additionally, the idea of doing antibody testing is a little suspect, because a lot of the tests are not actually doing what they claim to be doing. And so we're concerned about, false kinds of responses. However, if they're doing actual case follow-up, they're going to identify them.
A couple of questions kind of about, one about, do we know if there's an immunity in people who've been affected? And then another question from John Chalice about what do we know yet about kind of long-term health implications of people who've had the illness. I know talking with Phil the other day, I think you said your mother had the flu and it had long-term health implications from that. So what do we know kind of about people who've had it? Are they immune? What negative ramifications might there be also?
Well, first of all, as far as the immunity, with most infections, when you develop an antibody after you recover from it, it protects you for a long period of time, perhaps for the rest of your life, against that particular strain of infection. In this instance, there have been a number of cases where people who had antibodies got infected. The numbers are too small. We don't know. So they're unwilling to say you're protected, you're safe, you don't have to. Until we hear differently, I think you should continue to mask when you wear a mask and use good hand washing. And yes, my mother was alive and had the 1918-19 Spanish flu at age 2, and it was a lifelong pulmonary cripple basically because of that. And we're starting to, these things pop up. I mentioned the strokes in young children, kidney injuries, some neurologic impairment. So I think, as with most of these serious infections, there may be multiple complications that will pop up for years that we do not fully understand.
Let's move to the public health measures, and maybe I'll combine a couple of these questions I sent you. But on the one hand, we're all making sacrifices as part of a shared endeavor, and so I'd like each of you to at least take some time to say, what do you find inspiring in the current moment, so we can have some positive parts. The other issue that I raised in the questions I sent you is that we also know the public health measures themselves have their own ramifications. We've read about increases in domestic and child abuse, malnutrition, trauma, depression, and so how do we, I guess it's more a matter of how do we kind of, as moral people, as faith, how do we understand both the challenge to contribute to the common good while also understanding some of the negative aspects of the public health. And relative to that, one of the questions that someone sent was, why did we shelter in place for this one when we didn't for some of the diseases over the last 20 years? So there's a lot to answer there, but let's take some time to think through all of that. Bonnie, why don't you start as our public health person? So
What would you like me to focus on in that?
I don't know. Just we'll spend a while on all of those issues. So maybe I'll come back and ask the questions again. So maybe just start. What do you find inspiring? Let's start there. So
okay, what I find inspiring is from a wide variety. I find it totally inspiring to listen to Dr. Poor. She's so calm and so comfortable with what she's saying, and convinces people that, yeah, we're doing the right thing here, but it's going to be hard, but we're doing the right thing. And a couple of other things, like I saw an interview on television with a couple of pork producers in Southwest Iowa. And one of them was panicking about having to euthanize his hogs and having to not have what they needed to send to market for people. And the other one, and he said, yeah, he was euthanizing, the first one was euthanizing his hogs. He was, woe is me, and everything's going to fall apart, and how can they make us do all this? How can they say we have to stay home when we've got to be doing the things that provide food for the country? And the other one, that one really turned me to a flunk. And the next one was like, I'm going to do everything I can to keep these hogs alive. I'm not going to give in right now and euthanize them because we need them eventually. And I'm not going to say that pork plants should be open, because those people are not people who should have to suffer for what's going on with the rest of us that get to sit back and not be at work in dangerous conditions. And just knowing that they're maybe proud to be an Iowa farmer, just knowing that there are people really behind the effort and believing in it, even though they're making big sacrifices.
I've really been inspired by the people on the front line. Some people will drive to New York City and help them with their overwhelming.
Yeah.
And I think so. And Bonnie mentioned pork producers. A lot of people we traditionally don't think of as frontline people, but security, maintenance, people that drive the UPS trucks, on and on and on. They're in harm's way voluntarily, and I think that's just many of these disasters seem to bring out the best in people and the worst in people. But the best I've seen is people on the front lines, without a doubt. And I think there's opportunity for your second part of the second part of your 5-part question. Opportunity for creativity using social media, handing notes out through the doors, and having dinner parties where people are across the street from each other and waving. I think just the way it shows the human spirit in a number of different ways.
I walk in my neighborhood, and my route crosses 52nd Street going north and south, and Blondo going east and west. And it's interesting to note the number of people when you come to those intersections, because these are all stop sign regulated, who will wave you on to cross the street. And so being a physician who was used to thinking about measuring things, I would make a mental note of this. And before this event, why probably only about 30% of the cars would stop and wave me on. And now it's usually 60 or 70% would wave me across the street. So I think and there will be some interaction. There will be some sort of waving back and forth and acknowledging drivers and myself. And so I find that the level of awareness about other people in that scenario is pretty different.
Okay, so why did we getting feedback somewhere? Okay, so why did we shelter in place for this virus when we may not have for some of the other recent ones, SARS, Ebola, H1N1, etc.?
I think we shelter in place because number one, because this is a virus that just turned into a pandemic fairly quickly. It's highly contagious. Some of the others we've seen lately, like Ebola, are not highly contagious. They're highly lethal, but not very contagious. You have time to prepare for them. And some of the other infectious diseases were restricted to China primarily, or Africa, or other parts of the country. It didn't pose an immediate threat to virtually every state in this country. So that's why we employed that. It's a low-cost measure that has been useful in a number of infections in the past.
I would add that the strength of the imperative for doing that is to make sure that the healthcare system didn't become totally inoperable because of demand. So because we really didn't know to begin with how much that would occur, and so that's still potentially a risk in the next few months that could still happen, I would think.
Absolutely. That, as you watch the numbers, even in Douglas County, which doesn't have, big pork plants, and that's and most of our nursing home outbreaks have been, they're there, but they haven't been overwhelming. And still, the numbers are rising every day. And so at some point, we could very easily still be overwhelming the healthcare system.
So help us understand the moral weighing of, knowing that the lockdowns, the public health measures have their own harms and outcomes with obviously they also have a good, that they prevent the spread of the disease and more people getting sick and dying. But that in essence, we're living in one of those moments where every decision we make has both good and bad outcomes. So how do we medically and scientifically, and then maybe just you as people of faith and moral people, how do you understand that and help balance it?
I think it is a matter of trade-offs. Certainly our major initial focus was on the medical aspects, making people well, helping people to survive the infection. And I think that was appropriately, because it still is a focus. And as you go on, you start to become aware of the side of the mental health. There are more and more articles about mental health aspects of not just individuals who have been close to someone who had COVID, but other individuals who just had to shelter in place. And long-term effects of that. We may be headed for a much longer course than that. So it is a matter of trade-offs, and I think that the trade-offs, each side of the trade-offs has their advocates, but there's no way to solve both of those issues at the same time, to solve them completely.
I'm always struck by the complexity and unintended consequences of healthcare decisions, and we have them everywhere. And the fact that we're not allowing legislation to go through that will cover everybody for everything is something we have to work with all the time. Each day we're making decisions about who gets the kind of treatment that they really deserve and who doesn't, basically based on finances. I don't think they are, we do it this way or we do it that way. I think that they have to all be taken into account at the same time, and yet we have a lot of constraints on that. I do know that there are people who just cannot live in a house constantly with the people that are their family without having some real issues there, possibly, physical abuse, possibly just terrible depression, all sorts of things that will change how they function day to day. And that's one of the reasons I fell in love with public health, is because it takes so many things into account. You don't just take it from one. Like Douglas County figured out how we were going to be able to shelter people who were found to have positive tests but could not go home because they didn't want to expose anybody there. And so they found ways to set up hotels or motels, I'm sure it's smaller than that, that could take just those folks so that they weren't exposing somebody else, and they could still be with other people to give them some kind of support. You have to consider everything, and it's confusing at times which one you give more weight, but I just think you keep looking at all of the aspects, and yes, it's overwhelming sometimes, but that's where I come down. You got to look at it all, and maybe you're not going to be able to handle it all, but you still have to consider it.
So one of the questions that went across the banner, I think, from Nicole was, what do we think about the state loosening up regulations, letting people out? And I think they're doing it in a graduated fashion. But I think that points out, you're seeing violent protests on both sides. People that say, let us open our businesses, we're going broke. And other people that say, there will be people who get sick and there will be people who die in increased numbers because you're letting individuals out early, and there's going to be mixing and there's going to be spread of infection. So it's a very difficult issue. And my own opinion is that physicians and nurses are not necessarily very good at making those decisions, because that's where we look for help from philosophers and the clergy and so forth, because our focus has been on saving lives, and it's difficult for physicians to deal with, wrap their hands around the concept that there are people we would not be able to treat just because we don't have resources. The proverbial 2 sick patients with 1 intubation tube, what do you do? As far as, I'd like Bonnie to comment on this too. I think Nebraska is doing reasonable. I would personally would have been a little more conservative about letting down the restrictions, but other states have been more aggressive. But the thing about Nebraska that concerns me is we have not peaked in our death rate. We have not peaked at our infection rate. You'd like to see it peaked and heading down, ideally, before you loosen things up, but they may have had no choice.
Good point. I really do believe that, I mean, the process in other pandemics and for general in pandemics is that you don't start letting up on your restrictions for at least one, you don't even start until you had at least one incubation period for that particular disease, and that changes. And basically, yes, it is up to 21 days, but basically they're using 14 because of where the bell curve goes. And so that means that until the cases start going down, you really don't open up. And once they start going down for whatever determined period of time for each individual organism, then you ease something maybe if after 14 days, but you don't necessarily change mass things until you've had 3 of those incubation periods to determine that that's when you think you got it under control. So I mean, I think this is way too early. I do think that then the extra restrictions they're putting on, and I know how the health department and the mayor works together. The mayor and the governor are in charge of saying, this is what we're going to do. And the health department is in charge of educating the government officials to understand what the implications are here. And then, of course, I understand that the government is now trying to weigh those things and determine. I mean, they're struggling as hard as we are. I don't necessarily agree with what they're doing, but I know they have some pressures from other areas, and they are also valid things to consider. So anyway, the restrictions they put on, like for church services, really makes it so that if you're following them, you don't really open up. I mean, it's interesting to me that they're saying things like, okay, we're going to start opening up, but these are the restrictions. And most of us say, well, then that means we don't really open up because they're so strict.
You know, one of the underlying themes is the unexpectedness of the disaster and how that filters through how we relate and how we connect and how we have a sense of hope for the future. And you know, most disasters that occur are knowable. We don't know when they're going to happen or what their shape are, but maybe the message out of all this is a better sense of keeping track of kind of our disaster management. And I would urge that that instead of just a national and regional and state consideration, that these are communities and neighborhoods that eventually become involved, and how we structure our connections and support systems are valid for anyone at any time. It's of interest that, you know, we historically North America has a major tectonic fault involving a large section of land about every 300 years. And the last one occurred in the Northwest in 1770. But you don't ever hear about that, although the Californians are acutely aware of it. They have building codes about how you build buildings near the coast. And so it's not like they've been ignoring it. But I think that we don't have a means to, shall we say, structure local needs and the character of society within local communities that contribute to health and unstable health, and the ecological and cultural traditions that capture people within neighborhoods within cities are the major force for drives the stability of people's health nationally, and our overall level of social cohesion and how we interact with each other. So we have some fundamental issues that we could move on about recovering from this that need to structure those things. I'll just make a final point. Childhood maltreatment, childhood obesity, adolescent homicide, suicide, homelessness, mass shootings, substance abuse, midlife depression, disability, maybe even Alzheimer's disease are all related to the micro stressors that people endure every day. And these are not things that can be solved by standard healthcare that we think about. These are elements of how our society structures and is functioned, and the responsibilities that our faith community really already recognizes and works on. It's an amazing community as I've sort of evolved through various other faith communities. And so what we do and this session and how it's structured is emblematic of that. And in the long run, these will do more for the health of communities than an awful lot of things. One of the things you should also remember that I did not report is that our nation's rate of maternal mortality incidence has worsened now annually for about 50 years. We're the only developed nation with that statistic. And yet, and there are major efforts in place, particularly in the last few years, to try to solve that problem. But so far, there's been no evidence that it's changed. And it's hard not to imagine that the fundamental stress that we face every day in our society and how society has evolved to manage that is not a factor in all of these things, particularly the character of our support for young families and what happens during the first 2 or 3 years of life. And now there's beginning to be a new field of genetics called epigenetics, which there are hereditary processes, but they're not linked directly to the genome. And they all form during a pregnancy between the cytoplasm of the mother and the genome, because the ovum really represents the cytoplasm of the mother and forms the basis by which the genome explores it or expands itself during the gestation. So there are some elements to our social cohesion, not only nationally but locally and neighborhoods, that we have serious things we have to think about, and it's our faith communities that probably have the best sort of access to that within each community.
So one thing that seems to be a theme is that there's still a great deal of uncertainty and also ambiguity and complexity to this situation when you take in all of the various factors. Now, of course, we know human beings don't usually like uncertainty, ambiguity, and complexity. Humans generally seem to like things clear cut. They want to know what are the 5 things I can do that will work, and we're living in a moment where that's not all completely clear. So it seems to me that one thing that for a faith community to do in a moment like this is to help people learn to live with some uncertainty, ambiguity, moral complexity. One of the features we've been reading about is, moral fatigue or decision fatigue is now like routine little everyday decisions, like going to the grocery store, have vast life and death and moral, weight upon them. So this is, you're medical and scientific experts, but you're, fellow congregants. So how do you help us with this kind of larger moral and philosophical question? So what are the values that should guide our thinking and decision making, and how can we in this moment learn to live a little bit more easily with the ambiguity and uncertainty?
Well, let me just begin. I'll start with just one. There's a saying from Maya Angelou. Angelou, do I have it right? I think I do. Does anyone recognize that name?
Absolutely.
Oh, good. And maybe you know what the saying I'm going to quote is, right?
Probably.
No. Anyway, she is quoted as saying, what I've learned in life is that people will forget what you said, and people will forget what you did, but people will never forget how you made them feel. And the most disarming way of communicating that is just looking people in the eye and making it smile.
Which you can do with a mask.
That's right, but you can, shake your head or do something or to indicate some sort of acknowledgement. And I think what we do every day and how we treat each other.
I'm not sure if that sounded right. I meant you absolutely can look at somebody in the eye with a mask on and really make a connection. And I think everything you said, Paul, just really struck with me. I love Maya Angelou's quote because it's true for me. And I think that not only when we're 6 feet apart with a mask on, there are ways of doing it, but there are other ways of doing it too. I've had a couple of calls from people who just, I didn't realize they were calling to check on me. I thought we were just chatting. And finally I realized they were calling to make sure I was okay. And it just made me feel so grateful. And trying to figure out what kind of connections we can make with people under these circumstances is really valuable.
Yeah, then the church is a beacon of peace and stability when the world is changing rapidly. So anything you can do to maintain the connections, even I was talking to Sarah the other day about can you access the website and see the picture of the beautifully decorated altar when you're having insomnia and insecurity in the middle of the night. I think having sessions like this, all that you can do to continue to maintain that feeling of family is because the financial and the medical worlds may be changing and conflicting, but the church is the rock.
I'm having some connection issues, so hopefully you can hear me, but I was fine until a few minutes ago. But so one of the things, so we're not just experiencing a physical health challenge. That was kind of the primary presenting problem, but it's much larger than that. It really seems to be a complete impact on our wellness and our well-being, understood in the most holistic sorts of ways. And so I think maybe the most important question for us is, how do we live well with all of the various meanings of that word through this calamitous year? A phrase I borrow from Daniel Defoe. So how do we live well in all the senses of that term through this crisis?
One thing that just happened to me right this minute, I have a little Japanese maple that we planted in honor of my mother and father. I used memorial money for it. And whenever I look out my office window, it gives me such pleasure. But just a few seconds ago, a Baltimore Oriole lit in it. And I thought, what you do is, the best things we can do is take moments to really be aware of what's around us. And I think people are doing that more and more, and see what beauty there is and what meaning there is in much more ordinary things. I don't have a wonderful quote for it, but to me, it's seeing the beauty in the ordinary and taking from it what you can.
I think going outside in the garden, enjoying the spring blossoms is very refreshing and lets you move around a bit. And like you, I've tried to reach out to some cousins. I got a list of cousins that I haven't talked to in years, and I'm calling them up just to see how they are. And they haven't found anybody who's not appreciative so far.
Whenever I go to the store, I do what I can to connect with people without being obtrusive, and or just walking in with a smile on my face. I think those things make a difference. We don't realize that our connections, however we perceive them with the people around us, have multiplier effects. I always thought that Omaha had this small group of people who lived in the city, maybe it was a third of the city or a fourth of the city, who really maintained the vitality of the city because they indirectly knew everybody else. And I think that's true, and how we nurture that around us is important.
Okay, I have one more prepared question, and then we'll try to open it up for questions. Although it's been nice that people have been typing their questions so that we've been trying to answer them as we went along. When we open it up, hopefully that works and isn't complete chaos. But so last prepared question: what do you envision that the rest of 2020 is going to look like? And then through that, what do you think will be important for us as a congregation to be doing?
I think I could only speak to the medical part of it. I think we don't know. That came up earlier in our session. Several speakers, we don't really know what's going to happen. But the best predictions are that this will be with us at least for the rest of this year. And we'll have different parts of the country and different parts of restriction or lockdown. Areas that maybe including Omaha that have been relatively spared may not be spared. Something may pop up. This virus may turn into an annual cycling event like the regular influenza, or we may get lucky and with warm weather and the arrival of summer and a vaccine next fall that we could control it. But my guess is it'll be with us for a long time. But I don't predict the outcome for Big Red games very well, so I don't know how my record would be at predicting pandemics.
I agree with all of that.
Paul, anything you want to add?
No, I don't think so. I think what we do to help each other out and reach out, and our families, I think those are the main things, and as they always have been.
Okay, so let's try to do this without it turning into complete chaos. So anyone want to ask a question?
I did see one question back there from Sally, I believe, about where we would look for numbers and so on. That's been a struggle for me too, because I no longer have access to the resources that really allow me to look at what exactly is going on in Omaha and Douglas County and so on and so forth. I do check the Douglas County Health Department, and there are places where for a long time they said what their stated what their case count was and what their new numbers were, and that still changes fairly frequently. So I mean, I would check the Douglas County Health Department website and see if it's putting on what it is you're interested in seeing.
I guess where I was going with that is, how do we individually assess what our risk is beyond, knowing if we have some kind of underlying conditions where we would not do well were we to contract coronavirus. If we knew where the testing was happening, if we knew who was being tested, it might help us to better plan our day, I guess.
Well, I think the sources would be the Douglas County Health Department newsletter that you can go COVID Nebraska. For the state health department, that might be the best source. And the MMWR gives a brief overview. But it's very hard to predict. Right now, Adi Poor, who I also admire, has stated that if you go out, that restrictions are relaxed and you can go out to a gathering of such and such a size, up to 10 or 15 people, and stay 6 feet apart. But then she says, if you're elderly or in a risk group, then you should still stay at home. So we don't really know, even with testing, we won't know reliably if it's safe to go to Hy-Vee Peony Park, or if you should go somewhere else, or if you should have your children pick your groceries up for you. I think that all makes it very confusing. And I think Scott mentioned is also what do we need to do differently in the next year? Keep in mind that our demographic contains a fairly large number of people in the risk groups, and there may be ways to help them. But I don't think there's any website you can go to that'll give you the answer to where it's completely safe to shop, except if you go to hot rock concerts at downtown, you're probably in trouble.
One of the things I think about, Sally, is universal precautions, something that became very well used by everyone when we were talking about bloodborne illness back in the 90s. And what you do is you assume everybody has it, because you absolutely cannot tell anywhere you are that everybody doesn't have it. And so you always stay 6 feet apart at least. You don't go out in large crowds. You wear a mask, and we know there's different opinions on masks, but the fact is it's for covering your cough. It's constantly, you have a handkerchief there. So when you cough, it's not going very far. It also can kind of protect you from some particles and the way that they're determining that it's being transmitted. It's going to help you a little if someone were to cough on you, and that's better than none. The larger number of people you're exposed to, the more likelihood you're going to have a higher dose of exposure. And there is a difference in that. You can frequently being exposed to one person for a fairly short period of time, even if they're sick, may not cause you any trouble. But being exposed to 10 people who, over a period of the experience you encounter rather closely, it's going to up your possibility of being exposed. So
I should add that on my walks, 100% of the people I encounter on the walks honor distancing. They'll walk off into the street, or they'll stop in a driveway. I have not encountered one person in the last month who didn't honor. So that means everybody, or a very large percent of the population, is doing that. So from some respects, the fact that the level of awareness in society generally about all this is much higher should be reassuring in terms of uh, uh, our level of social cohesion, if you will. And I think the more we honor that um, spontaneously with the people around us, the more other people will do it, as the underlying theme.
When I get the news on the numbers in the state of in Nebraska, especially from the World Herald every day. There's an article in there every day that provides that information. Let me just say that my biggest concern we haven't discussed here, and that is all of the people in our community who are without income. I've just started working in the South Sudanese community and contacting all the pastors of South Sudanese congregations. I've only gotten 13 statements back. I'll have a ton of them, 100 or 200 Monday after church services. About $2,000 per month in expenses. They've been off work for 2 months. Most of them have, almost all of them have applied for unemployment, or situations where they're unemployed and applied for unemployment. They have not received anything. None of them have received a dime in unemployment benefits. That's people living $2,000 per month with no income. I mean, $2,000 per month in expenses with no income. And there must be thousands of those in this city. And my question is, I mean, and the Omaha Community Foundation has raised a total of $1 million, and they've already spent $500,000 of that on undocumented people, and 50,000 to the food bank. But that's not going to begin to cover the costs of simply surviving for people in this community who are unemployed. And I don't know what the hell to do about it.
Oh, John, you really did hit it. My daughter, our daughter, manages the kitchen for Meals on Wheels in Fort Worth, Texas. And the people who work for her are not paid well, but they have a job. But they are constantly, they don't call in sick. They don't not come. They don't, because they are the only income for not just themselves, but a lot of people who are not working. And Abby gets, I mean, her heart just is strung all over because she's in such pain when she sees what they're dealing with. We should have discussed that in this. And I do know that that should be a significant part of what we're doing in the next year, is trying to take care of those who maybe have permanently lost their jobs. And how we do that, I don't know. You know, we can donate, but it's a huge struggle. And it is one thing that the health department is trying to help people find places they can shelter when they need to. But as far as even getting enough food, certainly these are not the folks that are necessarily going to have lenient landlords that are going to say, okay, you don't have to pay your rent until you've got a job back. And the landlords will want to be able to feed their families too. This is one of the huge, huge aspects of how do we protect the health of the community.
Well,
Somebody,
we contact our, congressman and our elected officials, and let them know that yes, we want legislation passed, or a stimulus package passed that will help these people directly, not, well, I'll leave it there.
Scott, I think, is having connection issues. And so one of the things he is pointing out is that that we, since this is, we're all here and this is seems to be a good way to discuss this things, that this is fodder for another day of talking about this, because I think the economic ramifications go into a whole other, but it's related, but a whole bigger realm that we're kind of running out of time for today. One of the health questions that I have personally, and that I've heard seen other people say, is like, so right now we're isolated in this circle of friends, whether that's, a small circle of your household, or however your family is doing that. And I, for example, have a lot of family that don't live here that I'm not isolating with, that I would love to be able to see one day. So how do we go about opening up that circle safely, and when do we know we can do that? Beyond like tent camping at their house and like waving at them from afar. You know what I mean? So how do we do that?
Just before we leave the topic we're at, I don't think we need to be so discouraged. We need to take care of other people as we know they need care. And each of us has resources. And so making connections, and the church has one connection that we've already been working on with the refugee family. There are lots of refugee families, so that we need to use our networks to discover who needs help. And then we need to do what we can do to help them. Sorry, Katie.
Anyway. Yeah, we're gonna work on having a whole other day for all of these other ramifications, because we're not going to have a shortage. Like, there's not going to be a shortage of things that are related to this that we can all talk about. So,
well, the answer to your question is not known yet. It's complicated by the fact that every state has a different regulation. I was talking to a relative in Chicago, and they have a 10-person limit on the gathering. But it depends. If you have 5 of those or a family that lives together, you assume they're sort of in contaminated already if they're infected. So they shouldn't necessarily count as 5 random people or 10 random people you're having together. That advice will come from the governor's office. And I think in Nebraska, for instance, now you go to a restaurant, but you have to have 6 feet between tables and no more than 6 people at a table. And it's quite complex, but if the governor's office provides guidelines, those are going to change almost weekly, I think, depending on how the reporting of diseases goes. I think a lot of it's going to involve using common sense, and it's going to vary depending on whether you're in a risk group or not, and depending what sort of exposure. So some people will, if you have an electrician come into your house to fix something, I see people running around washing the doorknobs. Whereas if a relative comes in, you figure you're in equilibrium with them, you don't have to do that. So it's kind of a non-answer, but I just point out that there is no hard and fast guidelines. I think you have to use the common sense. The 6-foot rule and the scrupulous hand washing and wearing a mask in public are things that are pretty much agreed upon, but not even those aren't universal.
Anyone have a pressing last question? Because we've gone an hour and a half now, so we probably should wrap up. Don't see any. Okay. Well, Paul, Phil, Bonnie, thank you. And thanks to Katie for setting it up on the technical side and manage it from that end. Everybody have a good Saturday. Enjoy the lovely weather.
Thanks very much.
Thank you.